أحسنت.
Bismillah ar-Rahman ar-Rahim. Welcome everybody. It's today the night for the our regular monthly webinar from the Iraqi Australian Medical Association. We have the webinar today, Gynaecological Disorder. We have with us a prominent specialist. We have Dr. Midia Alias, Dr. Salwan Al-Salihi, Dr. Haider Najjar. مشكورين راح إن شاء الله يقدمون محاضرات. The first lecture will be by Dr. Midia Alias, heavy period.
Thank you very much. Thanks everyone, and thank you for the invite. Just want to make sure that my screen is shared. Can you see my screen?
Yes. Now you have
okay,
the slide. Yeah.
So my topic is about heavy menstrual bleeding. For those who don't know me, I'm one of the obstetrics and gynecology consultant in Melbourne. I work in both northern and western suburbs. Heavy menstrual bleeding, I chose that because it's really common, especially for general practice. And I still don't think that it's very well addressed and managed as a first line. So as we know, by definition, heavy menstrual bleeding is defined as an excessive menstrual blood loss, which interfere with a woman's physical, social, emotional, and or material quality of life. And it can be alone or in combination with other symptoms. And if we look at the traditional definition, it defines it as a blood loss of 80 or more mils per menstrual cycle. However, women can complain of excessive blood loss when the volume is much less than that. And the modern treatment guidelines do not actually require quantification of the blood loss to diagnose or treat heavy menstrual bleeding. Sometimes the woman comes in because they feel like the heavy bleeding affects their productivity, it impairs their daily function, it has negative impacts on their relationship with their family and partner, and also refrain them from their social routine activities, either at work or workplace. And overall, it can have negative impact on their self-esteem. And we always hear this, that I've been told this is just a bad period. It's very, very common that almost half of women may have poor knowledge about their condition. And over one third of them, so 39% of those women, when they diagnose with heavy menstrual bleeding, they might actually not know that there are treatment options available. And it's affect about 1 in 4 women, so 25% of women throughout their reproductive age. And women who always have had heavy bleeding in their life cycle, they actually think that this is part of their normal period life. So they will never address it. And as the patient presents to the general practitioner with the complaint of heavy period, the initial assessment should always include a detailed medical history, an assessment of the impact on the period on their quality of life. Always exclude pregnancy because that's the most common cause of the abnormal bleeding. And physical examination really helps if there is an obvious cervical polyp or masses in the cervix or abdominal mass. That can actually be the first thing that they will notice if there is a large fibroid, and it can be easily missed if there is no examination. And of course, later on, if that continues, signs of anemia will be what we can notice. In the history taking, we can especially concentrate on some of the things that can tell us that the bleeding is much heavier than normal, like the duration of the bleeding, the number of days, especially if it's more than 8 days, and presence of clots in the blood loss, if there is bleeding between the periods, if there is pain or pressure symptoms, or if they present with other symptoms of anemia like tiredness, fatigue, general body aches and pains, and other symptoms related to other illness, like thyroid diseases or polycystic ovary, now we call it PMOS or polymorph ovarian syndrome. If they have any other condition like diabetes, kidney diseases, or they are high BMI. If they have any other abnormal bleeding, that can lead us to possible bleeding disorders. Are they taking any hormone replacement therapy? Do they have any other gynecological history in the past that require treatment, especially polyps or fibroids? And what is their overall plan for their reproductive history? Are they planning to have more children, or they have completed their family? Because that will all impact on the treatment options that we choose for that patient. And it's always worthwhile asking if they have had any treatment, what was the success of the treatment, and what is their overall expectation of the treatment. To simplify the language of talking about the symptoms of, or the main causes of heavy menstrual bleeding, the International Federation of Gynae and Obstetrics classified the causes into structural and non-structural causes with the acronym of PALM-COIN. That details the structural causes into the polyps, adenomyosis, leiomyomas or fibroids, and malignancy or hyperplasia. And non-structural causes that listed in form of coagulopathy, ovulatory causes, endometrial causes, or iatrogenic causes like use of medication or hormone therapy, or other causes that we might not actually still know the reasons. The first line of investigation will include the measurements of the full blood count, the hemoglobin, and the iron studies. Thyroid function test always included because that can impact directly on the period. Von Willebrand factor, especially if the patient is a teenager or they present with their first few periods and it's heavy and hemorrhaging, and if they have family history. PTSCG to exclude pregnancy. And then moving into radiology with pelvic ultrasound as a first thing to measure the endometrial lining and also detail any structural causes, mainly polyps or fibroids. And from that, we determine if the endometrial biopsy is required. Why we do that? Because we know that risk factors or patients with risk factors for endometrial cancer, they can actually present with abnormal bleeding and most likely heavy bleeding. Things like high BMI, especially if the patient have other comorbidities with hypertension or diabetes. If they have history of chronic anovulation or infertility, that will make the endometrial lining become thicker and therefore abnormal or hyperplasia. Nulliparity always increases the risk. And if the patient have been exposed to anabolic estrogen, either prescribed or over the counter, or if the patient have been taking herbal medication or remedies, but that might actually be estrogen hormone without opposite progesterone. If they have been exposed to tamoxifen or the treatment of breast cancer, that can always impact on the endometrial pathology. And if the ultrasound scan shows thickened endometrium over 4 millimeters, especially in postmenopausal women, and if there is changes of cystic changes on that endometrium on the ultrasound scan. If there is strong family history of endometrial or colon cancer, that will always raise the possibility of possible malignancy. The treatment choices are available, and it's always good to do that with shared decision-making with the patient, because once we provide the patient with the treatment options, then they can choose based on their condition and the treatment option that is suitable for them, taking into account cultural or religious considerations. For example, I have had patients where they say, when I say we'll use the intrauterine device or the Mirena IUD for heavy periods, they will have objections because they do not want to use contraception, and that's against their belief. And we need to inform the woman of the benefit and the risks of any possible treatment, educate them about the possible side effects and the complication of that treatment, but also it's important to make them aware that there might be possible treatment failure. Not all treatments will be 100% successful for them. Therefore, we have to try the first option and then move on. If we rule out significant pelvic pathology or malignancy and we don't have any suspicion of that, then the first line of treatment, but in no any specific order, is medical treatment. The levonorgestrel or a Mirena IUD is very, very effective and useful. Combined oral contraceptive pills is also useful, especially if the woman is under the age of 35 and in need of use of contraception. Tranexamic acid or non-steroidal anti-inflammatory drugs also helps, but only by about maybe 25 to 30% in reducing the menstrual blood loss. And the use of hormonal cyclical normosterone or injectable long-acting progestogens like Depo-Provera can also be useful in some patients. If we suspect any possibility of ongoing pathology, an early referral to a specialist is needed, especially if the patient has any physical causes of their bleeding like fibroid or polyps. If we use any medical treatment, especially in general practice setting, and there is no response, the patient still continue to have heavy bleeding for 3 to 6 months, then a referral to a specialist is required. And of course, if we have any suspicions of malignancy or the patients have more than one risk factor for malignancy. The surgical options that are available are really helpful if the patient has normal endometrial cavity. So once we do endometrial biopsy and we rule out endometrial pathology, uterine preserving methods in form of uterine ablation, either with the ultrasonic waves ablation or balloon thermal ablation. It's very useful. It's one-off treatment. No medication is needed. It's a day procedure and a general anesthetic, but the treatment, if it's successful, usually lasts for many years. And the one will not need any further medication after that, but it is non-contraception, so a different method of contraception need to be used. And also the patient has to have completed her family. So if there is a desire for pregnancy, an ablation should not be used. The other good surgical option is for removal of any uterine pathology like intrauterine or submucosal fibroids or polyp by hysteroscopic resection or myomectomy. And that is really take care of the pathology instantly. And it's also a day procedure, quick recovery, back to work the next day. And basically the pathology is over. For fibroids who are not inside the uterus, so either submucosal or outside the uterus, then fibroid necrosing procedures like Mr. Jeffers or uterine artery embolization can be used, but really the value and the success of this procedure is limited to the patient's age, desire for pregnancy, the size and location of the fibroid. So generally speaking, it has to be more like over 1 fibroid and less than 5 centimeters, better, 5 centimeters or less in size, but also has to be outside the uterus, not inside. Once all the treatment option is being mentioned, or if we have tried the medical options are not successful, or alternative options are intolerable or not a desirable one for the woman, or if the woman wishes to have a hysterectomy, then of course the hysterectomy is a very effective method for treating heavy periods. But it's a big procedure and requires 2 to 4 weeks of time of work, depending on the method of hysterectomy. But for some patients, that might be the only option. So in summary, heavy menstrual period is a very common condition. It has significant impact on the quality of life of a woman. However, many women have poor knowledge of their condition or treatment available. There are lots of numbers of structural and non-structural causes for the heavy menstrual bleeding, but once we go through it all, there are underlying pathology for 40 to 60% of cases. No cause could be found, and that can be sometimes frustrating for the patient. In practice, any blood loss which a woman finds it significantly detrimental of their quality of life should prompt treatment, and we should not rely on quantifying the blood loss. And for any woman with heavy menstrual bleeding or benign causes, she should be offered the least invasive and the most effective treatment option first in an effort to improve their quality of life and minimize the treatment-related morbidity. Thank you.
Thank you very much, Dr. Midia. Thank you very much.
Thank you. I think we'll leave the questions to the end if you want to.
Yes.
Is Dr. Salwan Al-Salihi موجود? I don't think so.
I sent him a message.
Maybe Dr. Haider Najjar.
Yeah, you can start, Dr. Haider. I will give him a call.
Yes.
While you do that. Thanks.
تريدون أبدي؟ I can do that.
Yes, please, Dr. Haider. You
Okay.
can share your.
Let's see if let me just share the. Okay, you see my
We can see the screen now.
screen? Yeah. Okay. Wonderful. I'll get stuck into it. Thank you again for IAMA to invite me. It's always lovely to make an appearance at IAMA meetings. It's they delightful and lovely bunch, and they're getting bigger and bigger, which is fantastic. For those whom I haven't met, my name is Haider Najjar, and I'm part of a Create Health and Create Fertility, which is an IVF unit, and I also teach at Monash University and the Peninsula University Hospital, the new one in Frankston, and I've had a long gig at Monash Health as well. The purpose of today's, let's see, why is that moving down? Okay. The objectives of today is to outline the fertility assessment in general practice and identify when referral is necessary. Just to go over the global landscape of fertility in Australia, the total assisted reproductive technology cycles in 2023 is over 100,000. More than 6% of women gave birth in Australia in that year received ART treatment. So more than 1 in 20, so 1 in 18 women received some help with fertility. Almost 15% of those patients were single women, and 4.4 or say 5% were same-sex relationships. So you can understand the community dynamics in fertility is not just your traditional heterosexual relationship. 1 in 7 cycles of assisted reproductive technologies is egg freezing, and this is also, as you can see, is increasing as time goes by due to the awareness of patients and doctors. 1 in 4 cycles attributed to male infertility. This is a reminder that it takes 2 to tango, and the male partners are often forgotten. 1 in 4 cycles had male issues. So for the GPs as the frontier at the front end of public health and community health, your role is really important and critical. And history, one of the most biggest aspects is the age of the couple. And due to the current way of life and change in lifestyle, people are delaying fertility, and that's why we're seeing increasing numbers of infertility patients. The time of trying to conceive, awareness of the fertile window, a lot of patients now are, they've got apps and they're fully aware of how that goes, but it's really important to stress on that. The frequency of sexual intercourse, you'd be surprised how many couples I see that they've been trying for a year or 2, but they have not been trying regular sexual intercourse during the fertile window. The pregnancy history is also important, and also drug and occupational history. Advice to partners about smoking, alcohol, and weight. You will see, we will talk about weight a lot in this 10 now 15 minutes with مكرمة اجتنا بالزيادة 5 دقائق. Thank you. And time of intercourse. The people relying on the basal temperature is not really that reliable, so we don't really recommend it very much. Watching for the increase in the mucus is also, these things are really difficult to monitor, and they're very subjective. The importance of folic acid. We recommend that all women in fertile age, whether they're trying to conceive or not, to use folic acid. So they build their reservoir, and when they're ready to try, then they will have enough folic acid in the system, and definitely for the first 3 months of the pregnancy. Um, I can't see that bit, so I just need to move that. I can't see it. Um, the weight importance, and this is really critical, and I'm sure you all see our Middle Eastern patients, the cohort of patients we look after, um, generally the vast majority are overweight. And the the culture we have in our community is changing, slowly, but not quickly enough. A lot of patients don't understand that the weight has a significant impact, the high BMI, the diet. So sometimes even a marginal reduction of a few kilos will improve fertility quite significantly. What are the causes of infertility? The age is really, really important, the most important factor. 1 in 6 couple need an intervention to conceive or suffers infertility, mostly because of the age. Male-related issues, as I said, 1 in 4 couples we see, 1 in 4 to 1 in 2 may also have male factor with or without female factor. So it's really, really important. We see a lot of women coming to fertility consultation by themselves, and it's really important at a general practice level to try to involve the men early in the piece. Female-related issues, the most important female-related issues are ovulation issues, and the most common one used to be called polycystic ovarian syndrome. Now we call it polyendocrine ovarian syndrome. Tubal diseases are still very common, most likely, or most commonly, I should say, due to PID, which still unfortunately quite prevalent. Combination of issues. In my practice, I see a lot of patients who have endometriosis and fibroids and ovulation issues and male issues all in one couple, and they can be complex and difficult to manage. But also, 1 in 6 couples we see with infertility may have also an unexpected or no obvious reason for the unexplained infertility as well. And they are the easiest to treat. Um, Organically, in the female side, when we talk about the body of the uterus, as Media mentioned previously, polyps and fibroids are common reasons for abnormal uterine bleeding, but they also can be causes for infertility. Fallopian tubes damage due to PID, most commonly, or endometriosis, or previous surgery and adhesions, also common. Endometriosis is very common. Nearly 1 in 10 women during their fertile age suffer endometriosis. Ovulation, still the most common cause of infertility, and polycystic ovarian syndrome or polymetabolic ovarian syndrome is the most common cause for it. The discussion that you at a general practice level have is really, really important. And I really encourage you all to use any opportunity when you see your female patients for any reason to take the opportunity and talk to them about their fertility. And I do that. I see patients with abnormal bleeding or pelvic pain or endometriosis. And I say, let's talk about fertility. And you'd be surprised how many don't even know that fertility is timed, and your best fertile time is yesterday, is the year before. It's really women are designed to have the best fertility in their late teens and early 20s, not in their 30s and 40s, where majority of women now try to start a family. Um, and reproductive planning is really important chat to have with the patients. The AMH over the last 10 to 15 years, this test has emerged as a really useful tool, and our understanding as specialists and general practitioners has improved over the years of this test. It's a measure of the ovarian reserve, which is the storage of eggs, whatever eggs left. Eggs are finite. Women are born with a number of eggs and they get consumed every month. And by the time women get to their 40s, the fertility potential will decline because the egg reserve will decline. But low egg reserve doesn't always mean lower chances of conceiving. Some women have a small number of eggs, but they're still ovulating, then they're still able to conceive. So it's important to make that distinction between those two facts. And again, use the opportunity of seeing patients for whatever other reason and talk about fertility, do IAMS test, especially for those who want to delay their fertility or those who have endometriosis or history of premature ovarian failure in the family, which is not that uncommon. So I would really encourage you to have that conversation with the patients. The initial tests that you can do are non-invasive tests, a blood test and an ultrasound. And I'm sure you all have this batch of blood tests for the pre-pregnancy, which include genetic screening, which is now bulk billed, and rubella, chickenpox, CMV, all the other ones, blood group, vitamin D, thyroid, all the other ones there, and a pelvic ultrasound. Just with the blood test and the ultrasound, you will be able to discover the majority of problems without subjecting the patients to any major invasive tests. GLP-1, Mounjaro, and similar have been the talk of town for the last year or two, and a lot of our infertility patients use it.
العمل بنظام الأمبيرات للمولدات وبشكل كامل. هذا
Okay, we just had a little bit of everything's fine. So it's really important that we have a good grip on the Mounjaro and similar medication, the GLP-1. And a lot of people now propose benefits for them, even for dementia, endometriosis, all sorts of things. And the theory of it, as I'm sure you will know probably this much better than I do, is reduction of weight will reduce also the general inflammation and reduce other issues. But the benefits can be indirect. And it's also important to know when patients use contraception, the efficacy of the contraception may reduce during the usage of these medications. When patients try to conceive naturally or otherwise, we would like them to be off those medications for 8 weeks. But there doesn't seem to be any issues with egg retrieval for those patients. What about the male side and semen analysis? It's also important to be able to interpret this test. The volume can vary, not that critical, but the count per mil, 15 mil is the 15 million per mil is the minimum normal level. More than half of those sperms have to be active, have to be motile, and more than 5% of the sperms needs to have normal morphology, which is the shape of the sperms. And a normal sperm will have a head, a body, and a tail. And abnormal morphology, in my opinion, is the most critical factor in the sperm analysis, and it's often missed. Most doctors would look at the numbers of the sperms, but the morphology is really important. And a lot of patients may have 1 or 2% normal morphology, which is low, and the number of the sperms in total is normal, and you miss the shapes of the sperms as a main reason for the infertility. So I'll show you some videos of sperms. I hope I'm not too late with time. So you can see this is a normal sperm. You can see the activity, and they move mostly forward. Okay. Not all the sperms move, but as long as you have more than half the sperms. This is a normal sperm. Okay, with the bells on. And you can see a lower count. You can see other cells in the specimen, but the sperms numbers are smaller. And you can see here the activity of the sperms is not great, and some of them move sideways. So you need forward progression. Okay. So when you read the report, you can have an idea how what the scientists look at. And there's also, you can see these sperms that are slow and abnormal. That's when intracytoplasmic sperm injection or ICSI would be helpful in IVF. So as a major guide, when to refer the patient to a specialist. If there are no indication of problem and the patient is under the age of 35 and they have been having regular cycles, no indication of a male issue, no significant pain that may indicate to endometriosis, then it's okay for them to try for up to 12 months before referring them on. And if they're over the age of 35, after 6 months. On the referral, both the male and the female names have to be put on the referral for Medicare purposes. And in general, we try to accommodate patients. The general wait is around 2 weeks. What fertility services do we have for patients? I'm sure you're aware of the intrauterine insemination or IUI with ovulation induction. It's a great option that is not so costly, not so invasive, and we can control the ovulation to the hour and introduce a highly concentrated sperm sample closer to the egg at a confirmed ovulation time. IVF, ICSI, which is the intracytoplasmic sperm injection, especially if there's a sperm issue. Ovulation induction, ovarian PRP. I'm sure a lot of you heard about platelet-rich plasma and the activation of the ovary, especially with women who have low AMH. We've started this at Create Fertility around 2 years ago, and we had really good success with it. That some of you may have seen that it made its way to the media, and also intrauterine platelet-rich plasma injection, which can help with the implantation with IVF as well. There is donor program for eggs and sperms, miscarriage care program, egg freezing, embryo freezing, and there's also pre-implantation genetic testing for patients who have recurrent miscarriages or known genetic conditions, may that be chromosomal or single gene defects. I think I have a couple of more minutes. Just a quick case. A 37-year-old newly gravida has been having regular menses, AMH7, and this may seem low, but for the age, at the age of 37, AMH of 7 is considered normal, and they've been trying to conceive for 15 months. The male partner is a 41-year-old. The sperm analysis showed 18 million per mil, and that's above the 15 million. Normal motility, which is more than half, and 2% normal morphology. So it's not a quiz. As you can see here, all normal apart from the percentage of normal sperm morphology. That has to be 5% or more. So in the absence of any other issues, this couple would need IVF ICSI. The next couple is a 41-year-old, 4 pregnancies, 4 miscarriages. They've been trying for 3 years. AMH is 11, which is considered really good and high for the age of 41. And the partner is 48-year-old, no children, normal seminal fluid analysis. When you look at this, the vast majority of miscarriages occur due to abnormal chromosomes in the fetus, and especially when the patient's their late 30s or early 40s. And this couple would benefit from PGT or pre-implantation genetic testing for aneuploidy. So there's IVF, where we can make a few embryos and test them. We pinch a cell from each embryo, and only embryos that have normal chromosomes would be transferred back into the uterus. And that will improve the chances of achieving a healthy pregnancy that lasts to term. Last slide. As I said, you guys at the forefront of public health and fertility health, and your role is critical to patients' success. 1 in 6 couples in general suffer infertility. Women's age is the most important factor, and IVF can be a really good tool to help a lot of patients in achieving a pregnancy when necessary, when indicated. The most important side effects that you need to be aware of for IVF is pretty safe, but ovarian hyperstimulation, which we can manage these days quite easily with the medications we use. And with the Medicare rebate for IVF now and the public options for IVF, it become quite accessible and available for a lot of patients. Thank you very much. I hope I didn't take too much of
not
more
at
than
all.
the 15 minutes.
Great.
شكرا دكتور حيدر. برزنتيشن رائع، عاشت ايدك.
No worries.
الان دكتور سلوان الصالحي اذا ممكن يسوي البرزنتيشن، ممكن يسوي شير لليور برزنتيشن.
Hey, نعم. I'm sorry for the delay. I had an overseas phone call that took longer than I thought. I'll share.
دكتور حيدر النجار، ممكن نسوي ستوب يور شيرنج؟
والله ده هحاول بس. Okay.
حاول أقوى.
Yeah. I think okay. Here we go. Done.
Okay. Yeah. Let me try. Okay, sorry, just give me 1 second. Okay. Everyone can see it?
Yep.
Yes, all good.
So, I'm going to talk about some update on pelvic floor management and across all ages. Just to introduce myself, I'm a urogynecologist and pelvic floor surgeon. I head the pelvic floor unit at the Royal Women's Hospital in Melbourne for the last 10, 11 years. And we have a few studies and few advances that we would like to share. So pelvic floor, it is slightly a frustrating subject because not a day passed by without actually someone saying that I didn't know how to approach this, and I don't know who to talk to, and I don't know who I should actually share that with. And that's why I'm going to have it actually in 4 sections. What is pressing in women's pelvic floor health? I could say very easily the answer for these questions actually is everything. Who's affected? Everyone. How to ask and approach manage? Just keep it as part of the approach for each and every patient. How is your bladder control? Do you have any problems exercising? Do you have any problems with your bowel functions? And what might the future hold? And does it matter really? I'll come to that in the last slide. The pressing issues, and that specifically majority of patients come to general practice in relation to pelvic floor is recurrent urinary tract infections is number 1. Prolapse and incontinence in all ages, but younger ages are more and more, and I'll explain why. Asking the questions, are there any patients who are too old to treat? I'll come to that as well. And surgery. For some reason, we are very kind of like archaic and actually into describing surgery for pelvic floor, and we keep saying that that we keep referring to almost rhetorical statistics coming from the 90s and 2000s, saying, you know what, it doesn't work. You need to do it again, and things like that, which is it's in a major sense is causing the patients not to seek help after all. And why is it important to ask the patients for their pelvic floor health? Because it is multifaceted, it is interconnected to every single aspect of life, starting from diet to exercise, to daily health practices, to into relationship, into sexual health, into self-confidence, into psychology, into all of the above. I'll start with the recurrent urinary tract infections. By definitions, and this is actually defined for a number of years from the International Urogynaecology Associations, that having proven urinary tract infections with the counts that I mentioned here, 3 times over 12 months or 2 times over 6 months considered to be recurrent urinary tract infections. Meaning, unfortunately, women, due to the postmenopausal stage, as well as actually a shortenings of the urethra, they are more susceptible to have urinary tract infections, but having more than 2 in 6 months or more than 3 in 12 months is considered to be recurrent. But that needs to be conjugated with being proven beyond doubt with the bacteria isolated and grown. What's the most common bacteria? Everyone knows it, actually the E. coli. They are everywhere. The only difference, actually, I would say, and my observations.
هاي اليوم الطباخ.
Sorry, there was an interjection. That's definitely not mine. Okay. The E. coli is 80%. The quality of the E. coli's, I think, has changed since COVID. More and more strains of E. coli actually are resistant to certain antibiotics. I'll give an example. In year 2000, the epidemiology of Australia suggested that there is only 2% of E. coli are resistant to Keflex. And in 2010, there is 22% of the E. coli resistance to Keflex. And that applies to a lot of other antibiotic as well, including but not limited to, for example, to the use of nitrofurantoins, and hopefully he's not going to reach into trimethoprims and others. Staphylococcus can be about 10 to 15%. Enterococcus and Klebsiella are more difficult. Proteus are more difficult because they live in higher temperature, and they are less common causes for, but pay attention to the sensitivity. All patients who come to have the urine test, it's very important actually you can start the empiric treatments with, call it Keflex, call it nitrofurantoins, trimethoprims, but it's very important to present a sample, because without presenting a sample, you won't know what strain of bacteria have caused that infection. Is it sensitive to the medication that you give the patient? And very important, after finishing the course by 2 to 3 days, is to do another sample to assure resolutions of infections. The reasons behind it, statistics shows that actually 93% of the repeated infections is not a recurrent infections, but it is continued infection. Meaning that actually, especially the E. coli, has 2 ways of causing infections. They are attached. You can see that the tentacles attach themselves into the mucosa of the urotheliums inside the bladder, and through that they interject the toxins that goes into causing local and systemic symptoms. However, apart from that, it causes local inflammations and local irritations of the areas. So sometimes that after incomplete treatments for the urinary tract infections, the level or the number of bacteria available in the areas drop down below the thresholds of being picked up in the urine test, and comes back as there's pus cells, there is nitrates, but there is no bacteria. That doesn't mean that it's gone away. It means that that it will still there, waiting for the opportunity to reflourish again once the immunity drops down. And this is how it's classified as the reinfections and not a recurrent infection. For women who have recurrent urinary tract infections, I routinely start them on the cyclical prevention measures, which is antibiotics. Sometimes you can use 1 month of low-dose antibiotics, sometimes 3 months use of antibiotics. The UK is very fond of the long-term antibiotic protocols, 3 months of 500 milligrams of Keflex daily. Sometimes use antiseptics like the Hyprex or the Ural or some other available off the counter. And the local estrogen is very important, specifically for postmenopausal women. The introductions of the hyaluronic acids, chondroitins, bladder wash, which has a weird name, it's called Aialorol because it's Italian. This has been introduced about 15 years ago, and it was a game changer. It's an installation of 50 mils of the hyaluronic acids inside the bladder. Over 3 months, you do it 7 times. In Europe, it's 9 times. In Australia, by the TGA, decided as 7 times. What it does, it reduces the possibility of recurrent urinary tract infections for women over the age of 65 by up to 85%. And how it does that? It is replenish the linings of the bladder and provide a layer of protections between the bladder and the bacteria. Now, people who have used everything, and they still have the E. coli, and they sometimes infested in the bladder. It's quite difficult to get rid of it. There is the Uroimmune, which is a type of immunizations that it is enriched with E. coli, but it is has strains of Fecalis, vulgaris, as well as Klebsiella, and that is applied as a sublingual spray daily twice for 3 months, and that's needed to be we do apply to the Department of Health, and with current evidence that that a urologist, a urogynecologist, and a gynecologist can apply to it for certain patients, and the patients picks it up from the pharmacy. It reduces their symptoms, and it reduces the use of antibiotic, which is the aim of that vaccination. About prolapse and incontinence, age is gone beyond the previous realm of imagination. So nowadays, I see patients between 29 and 94, and every stage of life is very important. Every stage of life, there is different options of management. There are a number of solutions. Sometimes patients come back to me and say, look, you know what? The reasons why I didn't come, because I was told that there's nothing can be done since the mesh is gone. Nothing can be done. That's definitely not true. The cycle of the mesh and the mesh complications and all the media frenzy that came with it opened the door for a lot of other solutions. And I'll come to that shortly. Never too old to treat. So this is just some examples of managing bladder overactivity, which is considered to be affecting 1 in 3 patients for women over the age of 60. So it is very, very common. So if you have a waiting rooms have 10 patients, rest assured 7 of them will have bladder overactivity, and it's debilitating. It makes patients fearful of going and socializing, and it makes patients look for toilets everywhere they go. Some of the examples, like for example the Betmiga, it's not a new medication. It's been introduced probably about 10 years ago or more. Can be used, and you can prescribe it as well as GPs do. The one in the middle is it's called PTNS, which is percutaneous tibial nerve stimulations device. That's it's majorly subsidized, the session subsidized by Medicare. It's 12 sessions over 12 weeks with over 80% of success rate. And on the right is the Botox injections, and the Botox injection is very, very popular. The reasons behind it is because it's easy to administer. A lot of urologists, for example, do it in the rooms. We do it under sedation because we are less cruel than them. The other thing about it has a very high profile of success rates, up to 98%, and usually it is like magicals. It is instantaneous. So what about surgery? Surgery, they are very good. Their success rates in the first 2 to 15 years, it's close to 93%. The possibility of needing another surgery from native tissue repair, whether it is the anterior, posterior, or the apical, it is within between 10 to 15% over 20 years lifetime occurrences. The risk of the surgery is all surgeries have risk. There's no surgery without risk, but we need to have the conversations, give them the options, and then they can pick and choose depending on their current circumstances. Does it work? I can assure you it does work. So these are just an example of a few options. The mesh lift of the uterus is actually still exists, the sacrohysteropexy. We are going to publish almost 11 years of data of patients that we have done sacrohysteropexy for them. And after 11 years, actually, the success rates or the need for the success rate is more than 96%, and the need for repeated surgery for the uterus itself is less than 5%. The sacrocolpexy continued to be the gold standard procedure for bold prolapse, and the mesh is used as actually the same mesh that the bowel specialists use for rectopexy. It's been used over the last 15 years in Australia. The one below is called NASHUS, which is an acronym for novel apical suspension using harvested uterosacral ligament suspension. This is invented and created at our unit at the Royal Women's Hospital. We did cadaver workshops that we published about in 2025. They're both in the International Journals of Urogynaecology and the British Journal of ONG. We currently doing a comparative study between the use of the NASHUS versus the use of the mesh. If we reach the conclusion that it's not inferior, I can assure you that actually no one will use the mesh after. And it is in a major sense that actually it uses the same ligaments that actually is created by nature to lift the uterus or the vault or the colpus, and it's known to be elongated or stretched due to the pregnancies as well as delivery. So those ligaments then can be shortened, split into anterior and posterior leaflets on either sides, and reattached using prolongedly dissolvable sutures. The preliminary results so far is fantastic, but we don't have long-term data which we are working on. Now, is it important actually to ask about the pelvic floor when patients come to see the GP? I think it's a rhetorical question. It's very important. The ramifications of having pelvic floor dysfunctions is very understated, nominated, as well as actually as under emphasized among the society for different reasons. The fear of asking someone that will be rejected, the fear of having surgery that may fail, or have heard a lot of the bad outcomes. Unfortunately, bad outcomes are more easier to propagate in the media compared to the good outcome. And it has a major psychological ramifications. When women stop exercising because of leakage or prolapse, they tend to affect their mental health. They likely to gain weight. This will increase their possibility of having mental health issue and becomes a vicious cycle. Who's affected by it? You can see that between 30% to 43%, and you can see here that between the age of 30 and 39, 31% of patients will be affected by the prolapse and have symptoms. And in my experience, those are patients who they won't stop asking for questions and for answers, because they are different from the generations of the 70 and the 60-year-olds that they are not wanting to rock the boat, if you like. So those ones they would like to still run. They would like to do a marathon. They would like to do a high rocks. They would like to do a lot of activities and they feel they're hampered by the fact that with their pelvic floor dysfunctions. The management for the approach and the management at any level of expertise it is required. GPs should ask the questions. Start with the medications, with referring to pelvic floor muscle trainings, to advise about pessaries. If they feel that that it is not getting them the right answers, then referral to the pelvic floor specialist. Very important to a pelvic floor specialist. General gynecology, with all due respects, can manage them, but they have to be with interest. We are getting into more specialized field in the same way that the fertilities I would not venture in any way, shape, or form is advising about it in the same token. What the future might hold. There are some advances actually coming up. Some of them actually old, rhetorical, but just arrived in Australia. For example, on the left, there is the robotic single arm versions. Actually, it was established in 2016, but just made its way to Melbourne this year. And it's single port approach, which is very useful for pelvic floor units, much more than, for example, hysterectomies. The one in the middle is the PTNS, but it's an outpatient PTNS. They have the transducer inserted under the skin, and they can take the machine with them home instead of actually coming to the clinics every single day. And on the right, there's a new type of anticholinergic that actually works specifically on the bladder. It is Gamtesa. It's not available in Australia yet, unfortunately, but it looks like it's actually on its way in the coming 1 to 2 years. Thank you.
Thank you very much.
Thank you very much, Dr. Salwan. Thank you for all the presenter today. Thank you for their generosity and their kind to give their time and this nice presentation. I think we now open the questions. There's a lot in the chat. I think Dr. Haider Najjar was answering most of them.
Can we start with the chat, Dr. Essam? We're just answering the question on the chat.
Yes. I just go by. There's a lot of a question.
I answered the question, but I was still listening to Salwan and Midia. Multitasking.
It's multitasking on a plate.
Question from Dina. Many women will have just high BMI as a risk factor for endometrial carcinoma if they always have heavy period with normal endometrial thickness. Will they still need endometrial biopsy before IUD insertion, or IUD can be done through the GP? I think Dr. Haider Najjar answered that question.
Yes, I did, but I think Midia did that.
That's, you've answered it. So if there is no indication that there is endometrial pathology, like endometrial thickness is normal on the ultrasound scan, then there is no need for endometrial biopsy. The GP can insert a Mirena IUD, and we can do endometrial biopsy in clinic. So if we suspect any pathology, we can do endometrial biopsy and insert the Mirena IUD at the same time. Only if they have any structural pathology like polyp in the uterus or fibroid, then we do hysteroscopy to remove that and then insert the Mirena. So endometrial biopsy is not always indicated.
There's a question about, can Ovastin be used in pre-menopausal women for recurrent UTI? And Dr. Midia answered yes.
Yes. Can I just add to it? Absolutely. There is important concept that even women who are using oral contraceptive pills, there is disproportionate distributions of the estrogen into the vagina, and for those ones they benefit a lot from having the Ovastin vaginally twice weekly. There is no harm in doing that at all, and won't change anything in terms of their contraceptive practice.
There is admin question about the recorded version of this webinar will be available. Yes, it will be available. We will provide a link. It's usually in the YouTube. Other question, how long we should wait before we refer a patient for fertility assistant? Is it still 1 year of trying? Many thanks. Dr. Rima Hadi.
I replied to this and also mentioned this in the lecture. If there is an indication of a problem, if the cycle is irregular or the female is suffering dysmenorrhea or dyspareunia, if you suspect endometriosis or ovulation problem, then a referral should be considered quickly. But if there is no indication, and as a general rule of thumb, and patient is under 35 years of age, then they can try for up to 12 months. And if the female is over 35, and all seems normal, then 6 months. is these are lines in the sand, so to speak, rule of thumb. But we recommend that you use your judgment, and if you suspect there is a problem, they don't have to wait. Or if the patient is really keen to get help, then that's okay to get seen.
Shukran, Dr. Haider. Another question from Zoom user. What methods of pelvic floor surgical treatment do you think is the most effective, given we no longer use mesh? Many thanks. Rimal Hadi. This is Dr.
Sorry,
Salwan
I was going to
Al-Salihi.
apologize. It's before you kept going with the presentation, Doctor. So you answered this one if you want to move on. You said we still use mesh and here's a study. So I
Yes.
posted that before. Sorry.
It's not the vaginal mesh. The vaginal mesh does not exist anymore. The use of only the abdominal mesh for hysteropexy and colpopexy, but the Nashus is like I probably do more than 40 to 60% of my pelvic floor repairs using uterosacral ligament suspension, and it's getting very, very good results. But again, with that, eating my own words, that I think it's will show very good with the coming up studies.
So
but you can actually look it up for the study.
So what about slings?
Last year.
Do you still use slings, suburethral slings?
Still, absolutely.
That's another form of mesh that you guys still use, yeah.
Yeah, the incontinence surgery is still, now we have 4 options of incontinence surgery that we advise patients looking to treat stress incontinence. The number one is the sling, because TGA has approved the TVT, and it has continued to be the most successful procedure for incontinence ever invented, with the 27 years data suggestive of efficacy. I think the main issues that came up with the slings is because of the class actions. The lawyers wanted to lump it together with the vaginal mesh to get better outcomes, but in reality, TGA is read through the fine lines and still approve it to be used. But it's very important to be used for stress incontinence, not for something else, as well as is with a proven history, as well as as urodynamic testing. The second one is bulking agents. It's very popular for women over the age of 80 because it has no need for recovery. It's done under sedation, sometimes even under local anesthetic, and it has between 65 to 78% success rate. And the third is vertical suspensions. We're going back to the 60s, and we're doing more birches than we did before. And last but not least, for those very limited number of women who tried everything under the sun, we can still do fascial slings, which is the pure vaginal slings, taking the tissue from the rectus sheath.
There's a question: if hysterectomy was done and still ongoing bleeding, what does this mean? I'm not sure. Dr. Midia?
So first, it depends on when the hysterectomy was done. So if this is within the first 4 to 6 weeks of the surgery, that might be surgery related as a post-operative bleeding. If there is collection of blood or hematoma, and if it was done years after the hysterectomy, there should be no bleeding, but there might be the type of hysterectomy. If it's subtotal, which means that the cervix is left and the woman is under the age of 50, they can still get sometimes cyclical bleeding as a mini period. So these are the things that are important. But if the patient is within the first 6 months of a hysterectomy and they present with small amount of bleeding or spotting, especially with contact bleeding like postcoital, sometimes they can develop granuloma tissue at the side of the vault where we do the suturing. So it's worthwhile doing a vaginal examination to identify that. And I have seen a few patients with that. Depends on the technique of the suture materials, the post-operative infection. But if the hysterectomy is otherwise routine and complicated, and it's past the first 3 months of the surgery, then really, and the cervix is removed, then no bleeding should be expected.
There's a question.
Just a quick one to add here. Lovely answer, Midia. Great. I think some postmenopausal women may bleed from atrophic vagina as well, and much less commonly vaginal cancer in elderly women It's very rare, but that's also something that, as Media said, speculum examination for those patients is really, sometimes you just discover the main reason there.
Yeah, well, no, I missed the vaginal reason. So vaginal abnormality or tumors, definitely.
Thank you both of you. There's another question regarding day 21 progesterone test. How this can be calculated, when to be done, if the cycle is more or less than 28 days.
Yeah. So basically, this is a really, really good question, and it's one of the most commonly asked questions when we give lectures. The 21 ovulation confirmation test is done in irregular cycles when ovulation occurs approximately on day 14 and the progesterone peaks 7 days later. So if the woman is having regular cycles, you almost like don't need to even do a progesterone test. Regularity of the cycle is a testimony to the presence of ovulation. If the patient doesn't have regular cycles, there's no point of doing this test. You already have the answer. The irregular cycles, that means ovulation is not occurring at a predictable, regular way, and this needs help. So I know a lot of people try to chase the day 21 progesterone and they change the date based on the irregularity of the cycle, but you have the answer. If the cycle is irregular, don't need to do the test. We just need to find the reason and deal with it.
There's another question, unrelated question for HSDD. Would you try intrarosa in postmenopausal women before trying testosterone, and how long you will wait for the effect?
I can answer that if you want to,
yes.
because I have used intrarosa. So yeah. Intrarosa is vaginal pessary, which has progestogen hormone only. So it's a progesterone, which is a synthetic progestogen or DHEA. And it's used for vaginal atrophy for postmenopausal women because it should improve the elasticity and the atrophy of the vaginal changes after menopause. And it's been studied that, compared to Ovestin, which is the estrogen hormone. It works differently, but it does work. And in terms of the length, usually is about effective treatment, 6 to 8 weeks. But it's the downside of it is they require daily use. So most patients will not prefer to use it because they have to use it on daily basis. And it's a pessary, it doesn't come out in creams, but it can be used.
I have a question for Dr. Media. I have a lot of patients with the neurodivergence, young girls, and they usually get dysmenorrhea, heavy period, and most of them will get at the end diagnosis for endometriosis. But this is usually pelvic pain for years, no diagnosis for years, delayed diagnosis. Part of it is like most of the girls are unable to express themselves, and the other thing is that sometimes they think that this is a normal. Do you have much experience about this? What things need to look for?
I think Haider will be able to answer it better, but we do see those patients. For me, the reason for the delay diagnosis is because they have all the other symptoms, and there is usually a very big psychological component. So as you said, it's always presented and perceived as, oh, this is, a common presenter with this symptom is actually not the pain, it's their psychological component, which may delay the diagnosis. But I think there is a link, and Haider will be able to give us a better idea about that.
Thanks, Media. I think you've answered it beautifully. The average duration from the onset of the symptoms to the diagnosis for endometriosis used to be 11 years. And this with a lot of awareness campaigns and education for patients and us, also doctors, that has improved now, but it's dropped to 8 years. So it's still like it's a long time. So I think it's really important to have a good suspicion index for, when patients have pain is abnormal, and pain not managed by simple analgesia with menstruation or with sexual intercourse is likely to be endometriosis. On the top of that, we see patients with infertility who don't have symptoms, but just over 40% of patients who we see for infertility may have endometriosis, asymptomatic. So it's much more prevalent than we think. But if patient is asymptomatic and they don't have infertility, we don't go and stick a camera in their tummy to look for it. But when patients have pain, please raise the alarm as soon as you can.
Is dysmenorrhea and menorrhagia is part of the presentation of these patients, because this is very common
Yes,
happen with
absolutely. Yeah. Dysmenorrhea, dyspareunia, pain with sexual intercourse, intermenstrual bleeding, sometimes, change of bowel habits with menses. Some of them can be really subtle, just bloating and general discomfort. If you ruled out other GI causes, then it would be time to look at the possibility of endometriosis. And the main purpose of today, fertility as well. So a lot of patients who have fertility issues may have also endometriosis.
May I have a question, please?
Yes, go ahead. Introduce yourself, please.
Ali Al-Fiyad.
Yes, Ali, Dr. Ali.
Excellent. So my question is to everyone, but probably Haider Najjar to start with. I have 3 questions. One is about the use of GLP-1 in patients who you want to get them to lose weight. Is it safe to use it before they get into the IVF? So that's the first question. The second question is, what is the percentage of the patients you see for IVF? They are overweight, obese. They need to lose weight before they start the program. And the third question is, do you have a service or facility you send your patient to trying to lose weight and prepare for the IVF, like within the year before or the few months before, you get them to have a program that helps them to lose weight before they get involved in the IVF? Thank you.
شكرا دكتور علي، تحياتنا. دائما حلو نسمع صوتك.
Thank you very much.
Yes, the first question about weight and infertility, I mean, we cannot really overemphasize the correlation and the importance of weight. Weight can, at least it will affect negatively ovulation, okay? If it doesn't affect many other aspects of fertility. So there is a strong correlation, and unfortunately in Australia, in general population, but also in our Middle Eastern community, overweight, high BMI. If you look at the new definition of BMI, and I'm sure you're much more aware of that than me as a gynecologist, almost everyone we see is overweight, not necessarily obese, but this is one of the most common, maybe at least 1 in 2 patients I see with infertility would be at least overweight, if not obese. So it's a common problem, and it's one of those things that a lot of patients try to not to really, a lot of them may say, oh, I come from family of big people. We all built that way, and they're in denial of the fact that it's really what you eat. Okay, so that's in terms of the prevalence of it. In terms of the chances of success of any fertility treatment, including IVF, including surgery that we do for endometriosis or whatever other reason, we much prefer if the patient loses weight before we commence the treatments, because the chances of success will improve significantly, but also the chances of not just achieving a pregnancy, but also reduced risk of miscarriages, premature birth, gestational diabetes, preeclampsia, complications with birth as well. So we can sit here and just listen so many things. Until the weight loss medications, Mounjaro and similar, when people failed in achieving weight loss with diet, they had surgery, and the surgery, unfortunately, you have to wait 2 years after the surgery. My patients, I think it's a godsend for them, because in a few months they can lose quite significant amount, and they have to be off the medications for 2 months before we start any fertility treatment. So it can be used for a short period of time with really good results and a short lag before we start the treatment. The last question is about a facility for weight loss. We don't have such a thing. It's really the effort, mostly the GP, really the primary care. And in some hospitals, the Royal Women's Hospital, I think they have a metabolic clinic that helps with patients who are overweight, but I'm not aware of a fertility facility that helps with weight as such.
So if you have a service that we can provide, is that a good idea? We can partnership and we get you to refer patients, and probably the IVF treatment, the weight loss before IVF treatment can be a mandatory requirement before you get to the IVF. Is that, do you think, can help?
Yeah, I think partnering with any facility that would offer us, weight loss in a professional way, and we would love that. If a group of physicians like you or endocrinologists can be of help, that would be amazing. In terms of a cutoff, the problem is, Dr. Ali, we're dealing with a very sort of emotional demographics when it comes to fertility, and it's really hard to have a particular cutoff, because the age also is important, and other medical conditions, and if they have fibroids, if they have endometriosis, and there's so many other factors that we have to employ in the decision-making process. That makes the weight is just one of them. So it's difficult to isolate it. If the patient in their 40s, we don't have much time. We need to chop, get stuck into it. So, but yes, to the facility to help with weight loss, we would love that.
Excellent. We'll have some talk offline. Thank you.
Definitely. Thank you.
Thank you, Dr. Haider. Thank you, Dr. Ali. I think we conclude our presentation today, because almost approaching the 9 o'clock. Thank you very much for all
Thank
the
you very much.
presenter.
Thanks, Dr.
Thank
Midia.
you for the attendance, Dr. Salwan, Dr. Haider, Dr. Midia, and all the attendants. Thank you very much for all your time today.
Thanks.
Thank you all, and thank you so much, Dr. Haider and Dr. Salwan, for just saying yes to the invite without any hesitation. Thanks a lot.
No worries.